So you've also mentioned that you commonly see knee injuries as well, and I'm sure ACL tears and meniscal tears are two of the maybe the most common ones.
The way the injury happens is the way the knee is designed. It's designed to be able to move back and forward, can rotate. So the ACL will tear with a rotation type injury. The injuries are instantaneous. Within half of a second it takes for all of this to happen. Some patients can hear a one-time pop. For most injuries, we would like relative rest to calm down the initial episode of increasing swelling and inflammation.
A lot of times patients get injured and they want a very quick therapeutic approach where I need to fix this, I need to fix it now, I need surgery now. It's something that is usually planned. A patient has to be taken into consideration holistically, holistic management of strengthening and getting that patient optimal for surgery. And even after surgery, it is a long process afterwards with rehabilitation.
Definitely is. So there are many surgical strategies when it comes to reconstruction of a knee that's been injured. Only limitation there, though, is that you need to have a tendon, which is a stretchy string, do the job of a ligament, which does not stretch. So the time it takes to have that convert from a stretchy to non-stretchy state takes approximately 2 years and is 95% done by about 10 months. Pain and the swelling is gone, and the patient feels very good by 6 weeks and feels fully functional. Knee mobility is back by 3 months.
Hello and welcome to Orthosports Podcast. We are here to give you health, wellness, as well as fitness advice. My name is Dr. Rochelle Debedine, and I'm a general practitioner at Orthosports. And you will never believe who we have in studio with us today. It's no other than Dr. Moosa Kazim, the founder of Orthosports Medical Center, as well as a renowned orthopedic surgeon with over 2 decades of experience. Dr. Moosa, welcome.
Thank you.
So, Dr. Moosa, you are a very well known and respected orthopedic surgeon in the medical industry.
Inshallah, thank you.
Everyone knows you, praises you, and with an emerging population of doctors in Dubai, you have established yourself as such a successful orthopedic surgeon. And you never compromise on the quality of care of your patients. We would all love to know about your personal journey from your medical career to how you got to today.
Wow. Well, the journey was a long one.
Yes.
It started off in 1973, going to medical school. Our regional medical school was in Jamaica, which is an offshoot of University of London.
Yes.
Once I finished, I went for specialty training. I started off at McMaster University in Hamilton, Ontario, in Canada. And once I got my foundation there, I moved to Western Ontario, which is, I think, one of the better orthopedic training centers for clinical orthopedics. Once I finished there, I did a fellowship, meaning further studies, at the University of Miami, doing rehabilitation, diabetic foot care, and 2 other fellowships. One was in shoulder surgery.
Wow.
In Canada, and then a mini brush up for foot and ankle in Seattle. I returned there back to University of Miami as assistant professor at the university, and for personal and family reasons, left to go to private practice in Washington, D.C. for about 10 years, and then came back home. This is home base.
Yes.
Family's been here in Dubai for many years, since the end of the 18th century.
Wow.
And so I have a fairly extensive family here, so that beckoned me back home. Once I returned, I started Orthosports Medical Center. Soon after that, so starting in the year 2000. I
Okay.
set up Orthosports until here we are today.
Wow, doctor. No wonder you're an expert in your field.
Mashallah, thank you.
I think that as a colleague of yours working alongside you, we are so proud to be a part of Orthosports, and it's been such an honor working alongside you and being able to contribute to the high level of standard of care that you have set.
Thank
So
you.
today we're going to take advantage of that, having you here with us,
Okay.
and we want to absorb all the wealth of knowledge that you have. So we're going to discuss some very common orthopedic problems,
Okay.
and we're going to try and give our viewers and listeners as much uh, expertise advice as we can.
Okay.
Okay, so let's start off with sports medicine and sports injuries. And I mean, Dubai has a lot of people who are very fitness orientated and as well as take part in competitive sports. And I'm sure that you see a large number of sports related injuries.
Yes, I do.
So, can you tell us some of the common sports related injuries that you see?
Wow. Um, the list is really endless.
Yes,
I'll pick the top three most common.
sure.
So, number one, I think, would be ankle injuries.
Mhm.
Following that would be knee injuries and shoulder. These seem to be the three um, top spots where people tend to get injured. And the ankle
Yes.
mostly is one of instability, meaning they have a sprain when either barefoot or with shoes on, more so with impact sports, when they play basketball, volleyball, when they land. For
Yes.
example, if they land on another player's foot, the ankle will normally give out in a common direction, which is inwards. When it does, the outer ligaments, the stabilizers of the ankle, would begin to stretch and eventually tear. So this would be an ankle sprain, and there are different versions and degrees of ankle sprains,
Yeah.
and the way it is managed depends on the exact nature of the injury.
Sure. So most ankle sprains are managed conservatively.
Correct.
So if you have, example, a grade 1 versus a grade 3 sprain, what
Mhm.
is the usual, I would say, recovery period for these different grades? And is there a point where you're going to consider doing surgery?
The grade 1 and grade 3 sprains is a description of whether there is a tug, which is a
Mm.
grade 1, stretch, which would be a grade 2, or a tear.
Yes.
But the outer ligaments, which are the common ones that are injured, um, they don't participate 100% in ankle stability.
Mm.
So over the decades, we've gradually taken our focus away from the ligament injury and more focused on the ankle stability
Sure.
that it helps to provide. It doesn't provide it alone. So for the grade 1 or the tug, that can be treated purely conservatively. Sometimes we don't get to see the patient.
Yes.
When they continue walking on it, it doesn't cause any further injury. The pain seems to dissipate after a couple of weeks,
Sure.
and most of them are back to sports relatively quickly. The grade 2s and 3s are a little bit more involved.
Mhm.
So, with the grade 2 injury, when the ligament is intact but stretched, the nerve endings within them lead to a lot of pain and moderate amount of swelling. So for those, we still want to keep them weight bearing, because when you do with foot and ankle injuries, if you're able to walk them, the muscles continue to function. When they do, the blood flows, and we see that the recovery speeds up, recovery of swelling,
Yes.
recovery of pain, recovery of function, meaning you don't lose muscle strength. And so we try to keep patients weight bearing as much as is possible.
True.
And we have different strategies to do that for both the stretch and complete tear injury scenarios. So we would fit them with some sort of brace in the office, and the simpler the better. If they need to get back to sports very soon, then we do have more rigid braces that we could use. In the olden days, we would use casts,
Yes.
lately cast braces, which go up to the knee, and we found that they are overkill. Overkill meaning you immobilize the ankle, the muscles do not work. So you end up with weakness and stiffness requiring a lot of rehabilitation physiotherapy once the braces are off. So recovery time was a question. For grade 2, most of the pain is improving within a week to 10 days. And if the patient really had a need, we can fit them with a rigid ankle brace and get them back to their sports. Not as effectively because their ankle is rigidized, can't move as normally. But this will get them back safely. In the meantime, when they undergo physiotherapy, we begin to train them and prepare them for brace removal. Because at some point, the muscles need to be working again, meaning maintain the strength before they get too weak so they don't have a lot of strengthening exercises to go through. And when they do, we begin to train them with agility exercises, meaning speed of control as the brain commands the muscle to contract quickly and maintain stability, even in the face of a complete tear of the outer ankle ligament. So the outer ankle ligaments, when they're completely torn, the strategy is similar. If we focus on ankle stability, we can get them back functional. Literature says about 10% of people with a complete rupture of the outer ankle ligament end up in surgery. So the majority, 90%, can get by with conservative care. And depending on how quickly they need to mobilize, we can get them back on the paddle tennis court within a few days, not so comfortably. By 2 weeks, reasonably comfortably, and by 6 weeks, the plan is for brace off and return to normal function.
Great, sure. So you've also mentioned that you commonly see knee injuries as well, and I'm sure ACL tears and meniscal tears are two of the most common ones. Is it okay for you to just explain how a patient would present with these types of knee injuries?
So the way the injury happens is the way the knee is designed. It's designed to be able to move back and forwards. Yes, that's the simple part, but it also can rotate. So you can plant your foot and leg to the ground, but your upper body can rotate at the knee. What would normally hold all of the bones together would be the muscles. So if the muscles are strong, the muscles are fast, then you will maintain this knee stability. If you overcome that, either because of the speed of the injury or because there's fatigue of the muscle, then the continuing rotation or leaning of the bone would lead to first stretch of the next line of defense, which would be the ligaments. And if the forces don't stop, something will give. That's usually the ligament. So the ACL, the anterior cruciate ligament, will tear with a rotation type injury. When it does, the amount of mobility is so much that other things are injured within the knee, like the meniscus or shock absorber between the bone ends. You may get bone bruising of the surface of the bone, and the different degrees that each of this can happen. So the injuries are instantaneous within half of a second. It takes for all of this to happen. First, the stretch, then the tear, then the other injuries before the patient usually falls to the ground. So it happens very quickly, and some patients can hear a one-time pop. Some people can detect 3 separate, they'll get like rapid pops in succession, denoting each one of these, right? The tear of the ACL, then the tear of the meniscus, and then the knocking of the bones, giving the bone bruise in rapid succession. Some can actually feel the knee joint going out of place. It's not going out of place, but it's away from normal home base. And when it does that, the brain senses that things aren't fully together and get that feeling of being dislocated or out of place. So this is one of the, unfortunately, more common injuries that we see, where the ACL tears And then when it tears, it allows other injuries to happen.
Sure. So if you have a patient that is suspecting an ACL tear, they were playing sports, they had fallen, they now have a swollen, painful knee, they come and see you. What is our lines of investigations and how do we manage these patients?
For most injuries, we would like relative rest, ice, elevation to calm down the initial episode of increasing swelling and inflammation. Once it does, though, we need to mobilize the patient because the main bones are still intact. The joint is held together by other structures. And because of that, the knee, if you get it into a straight ahead position, tends to be stable. So, like other injuries about the body, if you can
Yes.
get the patient to walk on it, doesn't sound intuitive because they've just had an injury and they've had a
Sure.
joint injury. But were they to walk on it, the movement, the compression with the weight bearing allows the joint to maintain its health.
Sure.
Because joint health is done by um, oils that lubricate, and in order for them to do their job, they need to waft in and out of the cartilage, in and out of the meniscus. And weight bearing, yes, even on an injured knee joint, allows that. Second benefit to the weight bearing would be maintaining muscle tone and muscle strength so that the weakness doesn't accelerate. Three would be joint stiffness. So if you walk on a joint,
Yes.
generally the stiffness minimizes. At the beginning, it can be painful. So often we start off with assisted weight bearing using crutches.
Yes.
And then as they get better, down to one crutch and then no crutch.
Sure.
We have strategies for decreasing the amount of swelling,
Yes.
amount of inflammation, amount of pain. And we do that with medications. We do that with physiotherapy programs, which are both on-site and off-site, meaning within the physiotherapy center at Orthosports, we're able to begin activating the muscles, getting the mobility back while we're trying to investigate to determine the extent of injury and then definitive management.
Sure. Okay, so Doc, going back to investigations, what are some of the investigations that you would start with and work this patient up?
So, following the examination, you'll have a suspicion of the different types of injuries and the extent of each one.
Sure.
But to delineate them, we actually need imaging studies. Yes. Imaging studies would start with basic x-rays.
Of course.
Again, that is done in the office, and that will give us an idea
Yes.
of whether there are any bone fractures or any other issues that we could immediately identify.
Yes.
Following that, the next most reasonable investigation for knee injuries would be an MRI scan.
Yes.
So an MRI scan can give us a lot of information. It will give us information of the amount of swelling. It will give us information of the integrity of the ligaments, the bone bruising.
Sure.
If there's any cartilage damage, cartilage meaning the coating of the bone, if that has any injuries. Meniscus damage. So the meniscus is a shock absorber between the bones, which is commonly torn, and there are many, many different configurations. So once you have an idea of the number of injuries and the extent of each injury, then that will determine definitive management. This is done in conjunction with the patient because every patient has their own desire.
Yes.
As to what level of activity they're going to return to, whether they're going to return to downhill skiing. Yes. Or will give up downhill skiing if the option is surgery. They may choose to do that.
Yes.
So generally with isolated ACL injuries where there are no other major concomitant problems, we don't start with surgery. We start with physiotherapy because again, like in most of the joints nowadays, we focus on stability, not necessarily replacing a torn ligament.
Yes.
So if we focus on stability, we can again get the muscles activating.
Yes.
Keep them strong during a game, so endurance of that muscle, and then agility, which is the speed of contraction by training the brain once again to respond. And once we do, a fair number of patients are able to have a stable knee in the face of an absent ACL. The ACL, unfortunately, is one of the few ligaments in the body that does not heal. So if it doesn't heal, we need to get knee stability another way. People who have a higher level of participation in sports, especially pivoting sports,
Yeah.
so tennis, paddle tennis, basketball, volleyball,
Yes.
a lot of these unfortunately require rotation control. And if they at a really high level of participation, then they would need surgical intervention, even with an isolated tear of the ACL.
Sure.
If it is not only an ACL tear, if there are other injuries like meniscal injuries, so if there's a meniscus tear at the same time as an ACL tear, the present standard of care is to consider surgery for repairing the meniscus and protecting it with an ACL reconstruction. Why? Because if you go to the extent of repairing a meniscus and don't at the same time fix the ACL, the meniscus tear will recur. So generally, it's all or none. But we
Yeah.
try rehabilitating the patient in the knee, not just
Of course.
the injury. So the injury could be an isolated
Yes.
ACL, but it belongs to a knee. The knee belongs to a patient. So we have to keep the holistic picture in mind, where the patient doesn't feel like he or she is disabled and not able to return to at least a decent level of activity and help manage the stress in their day-to-day activities. So the definitive management would, yes, depend on the findings. And then in conjunction with the patient, we negotiate about the best way forward. If surgery is needed, it is best to be timed, meaning if there's an injury and you rush into another injury, surgery is another injury, then sometimes there's unacceptable amounts of swelling. So we wait till the knee has begun to calm down. And once we see that the swelling has begun to subside and the patient's motion is returning, we then, yes, we plan ACL reconstruction, meniscus repair, and try to get all of the components of the surgery done at one sitting so that there's concomitant healing and rehabilitation following that.
Yeah, I think the take home message there is rehabilitation. And a lot of times patients get injured and they want a very quick, therapeutic approach where I need to fix this, I need to fix it now, I need surgery now. But like you said, it's something that is usually planned. A patient has to be taken into consideration holistically, holistic management of strengthening and getting that patient optimal for surgery. And even after surgery, it is a long process afterwards with rehabilitation.
Definitely is. So there are many surgical strategies when it comes to reconstruction of a knee that's been injured. We've been doing this a long time, way before I started my training, where we've gone through carbon fiber, stents, stainless steel, many different strategies. And there are some people around the world who are still putting in synthetic ligaments, but just like before, they tend to fail. So the patient's own tissues using a tendon to replace the function of the ACL seems to be presently the gold standard. Only limitation there, though, is that you need to have a tendon, which is a stretchy string, do the job of a ligament, which does not stretch. So the time it takes to have that convert to from a stretchy to non-stretchy state takes approximately 2 years and is 95% done by about 10 months. Problem is the pain and the swelling is gone, and the patient feels very good by 6 weeks and feels fully functional. Knee mobility is back by 3 months. And a lot of them, maybe they don't follow instructions as closely. And because of that, they end up with a stretched out tendon. So it does take a combination of surgical care and post-operative rehabilitation in order to get the optimal results that we're looking for.
Of course. Thank you, doctor. So, if we have to take a break away from common sports related injuries, can we talk about the second burning topic, which I know you see a lot of, and that is tendinitis?
Oh,
I know you see lots of patients with tendinitis. It's
Mhm.
becoming ever so popular. And I think there are many patients at home who probably have been diagnosed with tendinitis. They're still not really sure what that means, what they have, and what are some of the causes.
Sure. So the term tendonitis means inflammation of a tendon. Tendon is the structure that the muscle uses to attach to
To
bone
bone.
in general. This is
Yes.
what a tendon is like. It's made of collagen, and when the collagen gets inflamed, and this could be from over exuberant contraction of a muscle in the gym, um, or you can actually have micro tears
Yes.
within the tendon, and that the same term is used, tendonitis,
Sure.
by patients to denote. So yes, very common. I would say most common would be in the elbow. So tennis elbow is a type
Yes.
of tendonitis. Golfer's elbow, the opposite side.
Yes.
Shoulder tendonitis of the rotator cuff, tendonitis of the Achilles tendon. So all of these are uh, different examples of a tendonitis, which can be very painful depending on the type and the location and the patient's physical activity.
So, how would you, if a patient has pain in their shoulder or their Achilles, they present to you, we've made a diagnosis of tendinitis. What is your usual approach to management of those patients?
So once we have the diagnosis made, combination of the patient's story, then examination, then usually imaging studies, so soft tissue imaging like diagnostic ultrasound,
Yes.
that will give us the diagnosis. And if there's any doubt or if it is a long-standing tendonitis, further soft tissue investigation with an MRI scan. So once you have the confirmation that it is, yes, a shoulder tendonitis, we have different strategies that we use. So generally, there are 4 levels of care. We go from medication to physiotherapy to injections
Yeah.
and to surgeries. The majority of patients seem to stop at the level of physiotherapy.
Sure.
So medications are good, but they've got 2 downsides.
Yes.
The most commonly used medication is an anti-inflammatory. So it's good for pain, but it has a funny side effect in that the inflammation reduction also seems to slow down a little bit the rate of healing, because the tendon, although white,
Yeah.
does have a small amount of blood supply, and that is what helps it to heal. And that seems to be curtailed a little bit by the anti-inflammatory. So we try to get them off as soon as it is possible.
Sure.
And physiotherapy. So physiotherapy has different modalities that they use. And a big component of that is an exercise program to get the muscle attached to the tendon function again. Because as you put tension on the tendon, the healing fluids, they breathe, they waft in and out of the tendon and would then encourage healing, as opposed to the old days when we'll put a limb in a cast
Yes.
or a sling. We found that that is not as useful because each of these treatments have their side effects. So if we keep the patient functional within the limits of pain, and then at physiotherapy, they will be able to begin activating the muscles, eventually strengthening the muscles, and then getting back to normal function of the shoulder or whichever joint has the tendonitis.
So, Dr. Musa, moving on to something that we very commonly see, osteoarthritis. It's one of the most common, I would say, common reasons of joint pain. And we find that our goal of conservative therapy would be pain reduction to probably improve the functionality of these patients, as well as halt or slow down the progression of disease. What is the role of intra-articular injections in osteoarthritis patients?
Osteoarthritis is very common. Knee osteoarthritis seems to be the most common, and it is very prevalent here in the Gulf for many reasons, gene-based and other reasons,
Yes.
activity-based, relatively common. So intra-articular or injections done into the joint,
Yes.
they have a place when it comes to management of osteoarthritis. And there are many different types. The most gentle is the prolotherapy. Prolotherapy, which is a combination of minerals or sugar injected into a joint, doesn't harm, and
Sure.
there's a small number of patients that would see benefit, mostly short-lived, but
Sure.
without harm. Then these injections can be repeated. Moving up into the chemical types of injections,
Yes.
corticosteroids goes by the name of cortisone
Yes.
in different configurations, has a place for osteoarthritis with a but. The but is that there are studies showing that cortisone in different forms can affect the collagen tissues in the body, and that includes in a joint.
Sure.
So it was very commonly done when I first started off practice,
Yes.
where anyone with osteoarthritis pain in the knee would get an injection of cortisone. We're now finding two downsides. The downside is that it's magic for pain relief. It is short-lived, and it leaves a funny side effect of accelerated wear of the meniscus and the cartilage coating of the bone. The second and more recently discovered downside is that if for some reason the patient needs the next line of defense, which would be joint replacement surgery, that if done within 1 year of the cortisone injection, there's a higher rate of infection. So now we're more measured in if we're going to give a cortisone injection and when we're going to give it.
Yeah.
Beyond that, we have other injections that could be useful. We have hyaluronic acid, which is an oily substance already within our joints, but given in a concentrated form. High level of success when it comes to pain relief, and seems to last approximately 1 year from when given, and no downside that we know of.
Yeah.
So it is a natural substance, and it can be repeated yearly.
Sure.
Which will help with pain relief, but it does not help with slowing the deterioration of the knee joint. So the progression of the osteoarthritis doesn't change. Beyond that, we have biologic substances of use, including stem cells from different sources and PRP or platelet-rich plasma.
Yes.
So stem cells have a place in knee osteoarthritis. They are unfortunately somewhat expensive, and they don't seem to have the benefit that we were hoping to get, because we don't know how to direct the stem cells to contribute to making new cartilage or synthesizing other structures within the knee. So PRP or platelet-rich plasma is often called a stem cell injection, but it is not. It is used from the patient's own body, where it would extract the blood, concentrate it, and the platelets, which have healing chemicals within them and the ability to clot, seems to provide two things, which is pain relief, which is one thing that we're after, superior to the hyaluronic acid, and two, they seem to slow down the rate of progression of the arthritis. That is not fully documented yet, because deterioration in osteoarthritis takes decades.
Yes.
But there's some good work showing that, yes, the PRP can help immediate and possibly help long term.
Sure. That's really interesting. And if we have to look at PRP, since it does have a little bit more benefits than the other injections, how often can one get PRPs done? Obviously, it depends on patient profile, but when is it that you're going to say no more? And now we need to look at possibly a knee replacement surgery.
Sure. So the studies were done using different numbers of injection at different intervals, and they recommendation is to give a series of 3 injections spaced at about a week to 10 days apart. That seems to give the best benefit.
Sure.
Anything less than 3 doesn't seem to do as good as 3. Anything more than 3 doesn't seem to add additional benefit than the 3. So the present recommendation would be 3 injections done a week to 10 days apart. How often this is done, meaning in the patient's lifetime?
Yes.
So that is an unanswered question. This injection is supposed to provide a film on the surface of the articular cartilage within the knee joint that is supposed to be lifelong.
Right.
I'm not sure I believe lifelong, but it should act for decades.
Sure.
Can it be redone after 1 year, 5 years, 10 years? Yes, there's no downside that we know of. And I do have patients wanting a repeat series, even though we don't have enough scientific evidence
Yes.
that it makes them better. It certainly doesn't make them worse. And they themselves feel more comfortable doing it. Yes.
Doctor, if PRP is not giving the patient the benefit that they want, now we're going to consider knee replacement surgery. Can you just brief us about that?
Sure. So knee replacement surgery literally means replacing the whole or the part of the knee. So in many instances, the majority of the knee is unaffected. Only one compartment, example, the inner compartment, is worn down, painful and stiff. And we now have replacements which are more gentle, involving replacement only of that part with metal and plastic components. And once the alignment of the knee is good, meaning it is not bent too much in an inner or outer direction, the knee replacement seems to last long, in the region of 20 years or so. And if the remainder of the knee is good, you've saved the patient recovery time, extensive operation, because replacing the whole knee joint, it's a somewhat bigger operation, a lot more involved when it comes to recovery, rehabilitation requirements. So we can now do partial knee joint replacements quite successfully.
That's great to know, Doctor. Thank you so much. Thank you for your time, your expertise. I know that there's a lot of patients that are going to be watching this, and they are going to be so grateful for your insightful knowledge that you've shared with us today. Thank you.
Thank you for having me.
I hope you enjoyed this podcast. I know that you'll benefit a lot from Dr. Moosa and his expertise. Remember, please subscribe to our YouTube channel. And I know you like this video, so please like and share to as many people out there. And if you'd like to book a consultation with our expert, Dr. Moosa Kazim, please feel free to click on the link below and we will gladly assist you. Till the next time, take care and stay healthy. Thank you.